Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and today we're going to be talking about drugs that activate adrenergic receptors. As you go through this series, whether you're here as a nursing student, a nurse, or getting ready for nurse practitioner school, these notes are available for you to print and follow along with at our website. So let's go ahead and start with talking about the adrenergic receptors. A few things I first want to point out. Adrenergic receptors are what gets activated to activate the sympathetic nervous system. This is also known as the fight or flight response. The primary neurotransmitter here is norepinephrine. And I want you to be ready to understand all of those terms, no matter how it's thrown at you on a test. Because if I ask you, what drug activates the sympathetic nervous system? Or what drug would increase the effects of norepinephrine? Or what drug acts as an adrenergic agonist? Or what drug activates fight or flight? All of those are actually relatively synonymous terms. So be ready for the test to ask you these questions in any variety using any of that terminology. So in the sympathetic nervous system, we have 5 receptors that are called adrenergic receptors. And they're broken down into alpha 1, alpha 2, beta 1, beta 2, and beta 3. Let's do a quick overview on the effects of each of these, and then we're going to discuss them in more detail as we approach each of these drugs. If I activate alpha 1, meaning I give you an alpha 1 agonist, I'm going to get vasoconstriction. If I block alpha 1 or give you an alpha 1 antagonist, I'm going to get vasodilation, the opposite. These drugs also, or this adrenergic receptor also causes prostate contraction. The prostate is wrapped around the urethra, and if it contracts, if it squeezes, it's going to squeeze on the urethra, which is going to make it harder to develop and sustain a flow of urine. By giving you an alpha blocker, I would relax the prostate, I would relax this contraction, thereby reducing that squeezing on the urethra, thereby allowing that flow to develop and or sustain. Next, we have alpha 2. Alpha 2 is sort of a checks and balance on the rest of the system, because alpha 2, what it does is when I activate alpha 2, I'm actually blocking the rest of the sympathetic system. And that's exactly what it's used for. It's meant to be sort of a check and balance on the rest of the sympathetic response. Beta 1 increases inotropic and chronotropic effects. Well, what does that mean? Inotropic means it makes the heart beat harder and stronger. Another word here is contractility. Contractility and inotropic are very close in terms, and they both mean that the heart goes ahead and it starts beating harder and stronger. Chronotropic effects means that it starts beating faster. Chrono is related to time, like chronology or chronological, and chronotropic means that it beats faster. These two together, inotropic and chronotropic effects that I get from activating beta 1, make the heart beat faster, harder, and stronger. On the flip side, if I block that, then I'm going to reduce how hard and how fast the heart is going to beat. Next, we have beta 2, which promotes bronchodilation, makes the vessels, the bronchus in the lungs bigger so that they can handle more air, so that they can get more airflow in. On the flip side, if I block that, I would be bronchoconstricting. I would be making it harder for a person to breathe. Never a good thing. Next, we have beta 3, which is detrusor, muscle relaxation. We're going to talk about that very briefly in a little bit. So what are the effects? If I went ahead and I activated the full spectrum of adrenergic stimulation, if I get the sympathetic nervous system kicked in, if I get that fight or flight response, what are going to be the signs and symptoms that as a nurse or a nurse practitioner, I can look out for? Well, we listed a few of the primary ones here. Dilated pupils is a big one. And that's because, again, I'm in fight or flight. I want improved ocular function, so dilated pupils. Bronchodilation, I get expansion of my lung capacity or of my bronchus, more airflow can flow through my bronchioles. Tachycardia, I get the heart beating faster. Hypertension, well, if I activated alpha 1, which gave me vasoconstriction, it made the blood vessels smaller, that increases my blood pressure, so that's going to give me hypertension. And then I'm also going to get decreased GI activity, because when we're in that fight or flight response, we don't need increased GI activity. We can put it on energy saver mode for right now, and let's focus on the heart, the brain, the kidneys, the things that are needed for that fight or flight response. So let's go ahead and let's talk about drugs that activate and inhibit each of these adrenergic receptors. We'll start with alpha-1 adrenergic antagonists, also known as alpha blockers. Some of the drugs in this class are doxazosin, prazosin, tamsulosin, and others. And these drugs work by blocking the effects of alpha-1. Well, alpha-1 causes vasoconstriction, so these drugs will result in vasodilation. Also, alpha-1 causes prostate constriction, which squeezes on the urethra and makes it harder to initiate and sustain a urine flow. This will relax the prostate and thereby allow the initiation or sustainment of a urine flow. What are these drugs used for? Well, two different things. One is related to the prostate, one's related to the vasoconstriction. So the two diseases we treat with it, BPH, benign prostatic hyperplasia, as well as hypertension, elevated blood pressure. I do want to point out that of the drugs in this class, some of them are used for BPH, some of them are used for hypertension, some of them are used for both. This class as a whole is used more for BPH, so we will see this drug class again when we get to discussing men's and women's health. Adverse effects of this drug, one very famous one is going to be orthostatic hypotension, which means that if I suddenly get up from a seated position or if I suddenly get up from laying down, my blood pressure can drop and the patient can pass out. This is definitely fair game for a test. If you see orthostatic hypotension, you need to make that connection in your mind. Oh, I better warn my patient not to suddenly get up from a seated position. Also, anytime you see orthostatic hypotension, that goes along with reflex tachycardia. Because reflex tachycardia, if you haven't seen this before, what does it mean? It means that the heart suddenly, as a reflex, shoots up the heart rate. Why would it do that? Well, if I have orthostatic hypotension, when my blood pressure suddenly drops, then my heart is going to suddenly respond to that with an increased heart rate. So again, what would be an effect of this drug, even though we know that it would directly cause orthostatic hypotension, you have to know that it will indirectly cause reflex tachycardia and be ready for such a question. Sexual dysfunction, this drug is known to cause ED. Obviously, that would be treated separately with another medication that we haven't covered yet. Another purpose for one specific drug in this class, phentolamine, is that it's used for extravasation. If you watch the first lecture in this series, we talked that extravasation is where an IV fluid that's meant to go IV into the vein starts to leak into the local tissue instead of only going into the vein. Now, if that fluid is a vasoconstrictor like epinephrine, now instead of causing vasoconstriction in my whole body, it's causing vasoconstriction right around the IV site. And since that's such a powerful drug and it's not meant for just this local area, it's going to vasoconstrict the heck out of those local tissues and those local blood vessels, and they're going to get complete cutoff of circulation. And they can die just as if they got a tourniquet placed on them. So in this case, phentolamine is used to treat that. We take phentolamine, we inject it directly into that site where this epinephrine, for example, leaked into the local tissue to reverse those vasoconstriction effects. Again, because this is an alpha blocker, it blocks vasoconstriction, which is what alpha-1 does. Next, we're going to have beta-adrenergic antagonists, more commonly known as beta blockers. This is a relatively famous class of drugs known as the LOL drugs, metoprolol, labetalol, esmolol, propanolol, atenolol, and so on. There's roughly at least 20 drugs in this class. And I want to point out here, we're talking about them as beta-adrenergic antagonists. However, technically, it should be beta-1 adrenergic antagonists, because would we ever want to block beta-2? Beta-2 helps us breathe. There's never a situation I would want to block beta-2. However, some of these drugs do have that effect. I'm going to talk more about that in a second. But I just want to point out that that's why this says beta-adrenergic antagonists instead of beta-1. So what do these drugs do? Well, we just said they block beta-1 receptors. Beta-1 is responsible for making the heart beat faster, harder, stronger. So this is going to make the heart beat less fast and less hard. It's going to reduce contractility. It's going to reduce inotropic effects, and it's going to reduce how fast the heart is beating. Do we use this for? We use this drug for a ton of different uses. We use it for angina, hypertension, heart failure, heart attacks, dysrhythmias, and more. However, we're going to discuss this drug again in detail as it relates to each one of these conditions, because this is going to come up in pharmacology over and over again. So we'll delve into it each time more individually as we talk about each of these diseases. The adverse effects of these drugs and the side effects, fatigue. Well, if I lower my cardiovascular output, then I'm going to have less energy. I'm going to have fatigue. If I block beta 1 from increasing my heart rate, I'm going to get a decrease in my heart rate, so I'm going to get bradycardia. And this drug also causes hypoglycemia. These drugs have a black box warning that you should not suddenly stop taking this medication. Again, these drugs have a lot of cardiac effects, both positive and negative, depending on the patient and the situation. But if the patient's heart got used to functioning with this beta blocker in place, and I suddenly stop taking it, it can cause adverse cardiac effects. Now, I want to touch a little bit on what we talked about at the beginning of this specific drug class. Some of these drugs are known as non-selective, some are cardioselective, and some include vasodilating. Let's touch on that very briefly. Non-selective means it's not selective to beta 1. So if it's not selective to beta 1, it affects beta 1 and beta 2. Well, beta 1 is what we're going for with this drug class. We're trying to lower the heart rate. We're trying to lower the inotropic and contractility effects. However, if I also get a little spillover effect on beta 2 because it's non-selective, then what am I going to get? Now I'm going to get a little bit of bronchoconstriction, because beta 2, if I activate it, I get bronchodilation. This is a blocker, so this is going to get bronchoconstriction. That's never a good thing, but usually it's a really marginal effect on beta 2. So the drugs that are non-selective, Panolol is the most famous of them. A beta blocker that is non-selective is going to have a little bit of blocking beta 2, which means making it a little bit harder to breathe. In those patients, you have to be very careful, because if they already have trouble breathing, if they have asthma, if they have pneumonia, if they have COPD, this would not be a drug you would want to give them. And that is fair game for your test, RN or NP level. Which beta adrenergic antagonist would be worst option for a patient with underlying COPD? This would definitely be the right choice for Panolol because it's non-selective. Cardioselective, that means that it is specific to beta 1 and has minimal, if any, effect on beta 2. That would be metoprolol, and most of your other beta blockers are going to be just cardioselective. Then we do have some of the newer ones, such as labetalol, that not only is cardioselective, that it slows down and blocks beta 1, but it also vasodilates. And we're going to talk much more about that when we get to the pharmacology of angina and heart failure, about what role that has in helping the patient's overall status. But we'll just leave it at that for right now, that labetalol is known as a cardioselective beta blocker, but also has vasodilating effects, so that it's going to dilate the blood vessels a little bit. And generally speaking, out of all the drugs we have for hypertension, we'll talk about this more when we get to hypertension, this is considered one of the safest options, because almost all of our go-to drugs for hypertension are not considered safe in pregnancy. It goes without saying, anytime I'm administering a drug to a patient that affects their heart rate, I need to assess their heart rate, both before and after. If I'm giving you a drug that affects your blood pressure, I need to assess your blood pressure before and after. So all the drugs that we talk about in this entire lecture, you need to be assessing at least blood pressure, and in some cases heart rate as well. A good rule of thumb, just assess all the vitals. That's not going to help you on the test, because the test will want you to know what exactly you need to do, but a good rule of thumb for practice is just assess all your vitals. When you assess one, assess all. Next drug class, we're going to start going through the agonists. So we talked about the antagonists, we had alpha blockers and beta blockers. Now let's go through the agonists, the ones that activate each of these receptors, and we're going to go through them one by one. So alpha-1 adrenergic agonist, that activates alpha-1. Alpha-1 causes vasoconstriction, so that's going to make it even more constricted. So that's going to increase our blood pressure. What do we use it for? We use it for shock and hypotension. However, also notice this drug, phenylephrine, is available over the counter in a nasal spray, and we're going to talk about that when we get to respiratory medications, but it's also available for nasal congestion. And how does it work there? Well, it causes localized vasoconstriction. It reduces the blood flow to the local area. And we're going to talk more about this drug in a few minutes when we talk about shock. Alpha-2 adrenergic agonist is really only one drug that's commonly used from this class, and that is clonidine. And this is used for a few different things. It's used for high blood pressure. And let's work our way through that for a second. If alpha-2 blocks the sympathetic system, remember this is the one that's a balance on the whole rest of the system. If this sort of inhibits the rest of the system, well, the rest of the fight or flight causes an increased blood pressure. If I give you more of the drug that blocks it, I'm going to decrease your blood pressure. It's also used off-label for pain, for some mental health diseases, and we'll talk more about that in separate lectures. Next drug class we have was beta-1 adrenergic agonists. We talked about antagonists, now we have agonists. So what are the drugs here? Dobutamine and isopropanol. What are these going to do? These are going to increase the inotropic and contractility of the heart, making the heart beat even harder, even stronger. And we're going to talk about that also in a few minutes when we get to shock. This class of drugs are IV only. These are really powerful agents. These are not given for just anything. These are given when we absolutely must increase the patient's cardiac output. We must give that heart a kick in the pants that it starts beating harder for whatever's going on with the patient. And we'll talk more about it in a few minutes. Next, we have beta-2 adrenergic agonists. This is albuterol, one of the most commonly used medications. It is the end-all be-all of bronchodilation. It is our best go-to drug when a patient acutely needs their increased lung capacity, increased broncho pathways. So this is our go-to drug for that. It's used for asthma and COPD. I'm going to leave it at that because we talk much more about it when we get to respiratory medications. Beta-3 adrenergic agonists, there's one drug here that we commonly see, which is mirabegron or mirabetrag. And what does this do? This blocks beta-3, and that results in detrusor smooth muscle relaxation, which increases our bladder capacity. What is this used for? You probably guessed it, overactive bladder, where the patient's peeing too much. If I reduce this muscle's contraction, I relax it, I allow the bladder to have more of a capacity, the patient doesn't have to go peeing as much. The adverse effects of this specific medication, this mirabegron specifically, is going to be angioedema. It's going to have cardiac effects because, again, it's dealing with the adrenergic receptor, so it's going to have a little bit of spillover, so it's going to cause a little bit of hypertension, a little bit of tachycardia. It may cause some urinary retention because as the bladder has a bigger capacity, we can start messing with other effects of our stimulation to have to urinate. Now that we covered each one individually, let's talk big picture about what to do for a patient in shock, specifically vasopressors and vasoconstrictors. Let's start by defining those two terms. A vasopressor and a vasoconstrictor are often used synonymously, however, they are not interchangeable. A vasoconstrictor is a drug that vasoconstricts, that makes the vessel smaller, or activates alpha-1, because alpha-1 is what causes vasoconstriction. So any drug that activates alpha-1 systemically would be a vasoconstrictor. A vasopressor, and I don't really know the semantics of this word, but pressor support means something that makes the heart beat harder and stronger. So a vasopressor is something that makes the heart beat harder and stronger. By this time, you should definitely be recognizing that means it activates beta-1. So a vasopressor activates beta-1, a vasoconstrictor activates beta-2. Let's talk about a few specific drugs that we use for these effects. Let's start with epinephrine and norepinephrine. Okay, two of the most commonly used vasopressors / vasoconstrictors. These two drugs are both. If I said a vasopressor, I said a vasoconstrictor. This is both because it activates both alpha-1 and beta-1. So it gets that pressor support and it gets that vasoconstriction. Another drug that we have is phenylephrine. Phenylephrine is only alpha-1. It has a tiny bit of beta-1, but for our intents and purposes, it's only alpha-1. So for that reason, this is a vasoconstrictor, not a vasopressor. Dopamine is a little bit different than all the rest of the drugs in this class. Dopamine does activate both alpha-1 and beta-1 when it's used at its standard doses, which is somewhere around 5 to 20 mics per kilo per minute. You don't really need to know that for the RN level. At the NP level, you definitely need to know that. But let's go over really quick. Dopamine at a low dose, which is less than 5 mics per kilo per minute. Again, at the RN level, you wouldn't have to know these numbers. It causes increased blood flow to the kidneys. And that's it. We use it to increase blood flows to the kidneys at a really low dose. When we get to medium dose, this is where it becomes comparable to epinephrine and norepinephrine, because if you look at it, it says the exact same thing. It causes alpha and beta activation. However, it also causes dopaminergic activation, which is back to that low dose, increases the blood flow to the kidneys, plus alpha and beta activation. When it gets to a high dose, over there, and it's a little bit fuzzy on what's exactly a high dose, it really starts to have a very dominant effect on alpha-1, which makes it similar to phenylephrine at that really high dose. And what that number is debatable. But when we get to that really high dose, over there it becomes almost entirely an alpha-1 drug, so a very strong vasoconstrictor. Again, I would just know for the RN level, at a low dose, dopamine is just used to increase perfusion to the kidneys. At a medium dose, it's used to, as the same as epi or norepi, to act as a vasoconstrictor, vasopressor. And at a high dose, it becomes pure alpha adrenergic agonist. However, I do want to point out as we're going through these drugs, all of these drugs, in this case, we're talking about them as an IV infusion. Epinephrine, norepinephrine, phenylephrine, dopamine, all of these drugs are usually based on micrograms per minute, micrograms per kilogram per minute, something like that, just so that you're never expecting a patient to be ordered to get 20 milligrams of this. That's not going to happen. It's going to be dosed per minute and possibly per kilo as well. The last two drugs on this list, we have our isoprotenolol and dobutamine. We talked about both of these a minute ago, and both of these are beta-1 activists. So these are definitely vasopressors, but not vasoconstrictors. So these are going to make your heart beat harder and stronger, but it's not going to vasoconstrict. Remember, vasoconstrict has a strong effect on our blood pressure versus beta-1 doesn't have nearly as strong of an effect on our blood pressure. And that's a good test question. What would be more likely to increase a patient's blood pressure, a vasoconstrictor or a beta-1 activator or an alpha-1 activator? Definitely an alpha-1. Alpha-1 vasoconstricts, that brings up our blood pressure. Remember, that's talking about what's going on in the vessels. Blood pressure is all about what's going on in the vessels. That should be intuitive to you. A vasopressor deals with the heart. And yes, of course, that has an effect on what's going on in our blood vessels, but not as much as a vasoconstrictor as an alpha-1. So let's go ahead and let's talk about all of these drugs because there's a ton to know about it. First of all, the mechanism of action we talked about. If it activates beta-1, that's going to make the heart beat harder and stronger. If it's going to activate alpha-1, that's going to vasoconstrict. If it's going to activate dopaminergic receptors, which is sort of a cousin to the adrenergic receptors, that is going to increase blood flow to the kidneys. What are these drugs used for? Well, these drugs are, generally speaking, are used for shock. They're used for a patient who is in shock. Shock, if you haven't learned this already, is a state of inadequate cellular perfusion. It's where we are not getting enough blood flow and thereby enough oxygen to the cells. All of these drugs are extremely powerful. All these drugs are strictly given in an ER and an ICU setting because they require constant monitoring, things like that. Adverse effects of these drugs or side effects are going to be tachycardia and palpitations. That makes sense. If I'm making the heartbeat faster, harder, stronger, then the harder and stronger is going to make me feel like my heart's beating really strong, that palpitation. Tachycardia, if I'm making it beat faster, then of course I'm going to get tachycardia as well. These drugs have a black box warning that they can cause extravasation. Remember, we talked about that a few minutes ago. That's where the drug, instead of going IV into the vein, it goes whatever you want to call it, IT into the tissue, which is never a good thing. We're not trying to inject it into the local tissue. In that case, we would treat it with phentolamine. Fair test question, what would be a method to reduce your risk of extravasation? First of all, closely monitoring the patient, ensuring the patency of the IV, but this would be another one that if you should give this medication through a central line to reduce this risk. That would be a big plus because central line is a much lower risk of extravasation. All these drugs are extremely powerful. For that reason, we never want to just eyeball the infusion rate based on drips per minute or anything like that. We always want this medication to be going through a pump, if at all possible, so that we make sure we're giving the patient the exact proper dose. If you give a patient too much of this, you can very quickly cause a lot of bad reactions. If you give them too little, then whatever's going on is not getting properly treated, and that could be a pretty serious problem considering this is for a patient that's in shock. This medication, remember, you're always going to be assessing the patient's blood pressure and heart rate before and after. And since this is an infusion, you're going to be constantly assessing a patient throughout this infusion. Any patient who's on this is almost universally going to be getting their vital signs assessed every 15 or 30 minutes max to make sure that we're on target with what we're doing. Most of these drugs are going to be, the order is going to be written as titrate to a specific systolic or a specific MAP. So in other words, put this patient on an epinephrine drip, 10 mics per minute, and you can go keep increasing it until you hit their systolic comes above 90, or until their MAP, their mean arterial pressure, comes above 60 or 65. Those would both be very common orders that I would expect with this medication. With this medication, we are going to very slowly increase it up from our starting dose, whatever starting dose is selected by the provider. And on the flip side, once we hit that target, we're going to level it out. And then if needed, we're going to slowly taper it down. We would never want to suddenly stop this blood pressure, even if the blood pressure came up, way up, 150, 160, 170 systolic, you're still going to slowly back off of it. You're not just going to stop your cold turkey. Dopamine specifically has a big adverse effect that is commonly tested on quiz banks and on different licensing exams about tachycardia dysrhythmias. That it's known it has a much higher risk of causing dysrhythmias, specifically very fast or tachy dysrhythmias when used, and that's a big disadvantage to dopamine as compared to epinephrine and norepinephrine. I do want to point out specifically that epinephrine, we're talking about it here, and this is where we're going to cover epinephrine, but it does come in two flavors. It comes in the 1 in 10,000 and the 1 in 1,000 concentration. These are absolutely not interchangeable. One is 10 times stronger than the other. One of them, the 1 to 10,000, is what's used for infusions. It's what's used for a patient in cardiac arrest. The 1 in 1,000 is what's used for anaphylaxis as an IV push or as an injection for an EpiPen. That's the 1 in 1,000. But these are two different things, and it's fair game, even at the RN level, to ask which drug is appropriate for what. The Epi 1 to 10,000 is what we use for an infusion. It's what we use for cardiac arrest. The epinephrine 1 to 1,000 is what we use for anaphylactic shock, aka an allergic reaction, such as an EpiPen. Finally, I want to be really clear on this because this is fundamental to understanding the pathophysiology of shock. Giving a patient this drug does not fix if they're in shock due to blood loss. So if a patient was in a gunshot victim or in a car accident and they're bleeding out internally or externally, it doesn't matter. But if they're bleeding out, then their problem, they're in shock. We agree on that. And shock is a state of inadequate cellular perfusion. They're not getting enough blood flow to the cells. But why? If it's because they're bleeding out, it's because they don't have enough blood to circulate. Me giving them this drug is not helping the problem. The problem is fixed by giving them blood. Me giving you this drug, it might bring your blood pressure up. That's what it's supposed to do. It's going to vasoconstrict, increase the beta-1 effect. So it might bring your blood pressure up a little bit, but it is not fixing the problem. If a patient has shock due to blood loss or volume loss because they're severely dehydrated, something like that, this would be a Band-Aid at best, and in fact, it can sometimes make the situation worse. We want to fix the actual underlying cause. If they're bleeding out, stop the bleeding, give them blood. Until we have blood, give them fluid, things like that. But this is not going to fix that situation, even if it does make the numbers look prettier. One additional point I want to point out, if a patient is in cardiogenic shock, where the heart is failing, and the patient is unable to get good cardiac output, the heart is not able to pump a good flow up into the aorta, me vasoconstricting the aorta is only making the work of the heart harder. Okay, we may do it temporarily to maintain blood pressure until we can save the patient, but again, keep in mind, that is not fixing the underlying problem. Their heart is failing and I give you a vasoconstrictor, yes, that will bring your blood pressure up, but it's at the expense of now making the heart actually have to work harder. Thank you so much for watching. Have a great day.